It is an honor for me to introduce the next speaker, which is Dr. Hisham Arab, who is a Saudi senior consultant in OB/GYN, a Canadian-trained and certified subspecialist in maternal fetal medicine practicing at Dr. Arab Medical Center, Jeddah, Saudi Arabia. He is a visiting professor in Weill Cornell Medical College in New York, USA, founding member and former Secretary General of Saudi OB/GYN Society, Deputy Secretary General of World Association of Perinatal Medicine, Chairman of Arab Maternal's Fetal Medicine Expert Group, Chairman of Ian Donnell School of Ultrasound Jeddah, and Chairman of the Saudi Endometriosis Group.
Give me a mic. I want mic, separate mic.
Yeah, the last one. This one?
Yes.
Hold on. Paste.
جيب لك مايك لان في حاله كده تتكلم قدام كده احسن شويه. ايه او من هنا مثلا بعدين سلايد. نفس الترانزيشن ولا؟ You did not bring it.
Yeah, this one.
ايه تفضل دكتور. It's working.
You just call them. Open this one.
او تبغى طريقه كده مثلا.
بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على أشرف خلق الله محمد بن عبد الله صلاة الله وسلامه عليه. In the beginning, I'd like to thank the organizing committee for this kind invitation, especially Dr. Sheef, to get me involved in a very highly sophisticated congress that really put the problem of thrombosis and its prophylaxis in one bowl. And I just want to deliver my share in this one. Well, he asked me to talk about the recurrent pregnancy loss and its relation with the thrombophylaxis and how it's important. Let me go back a little bit once and give you a history which will be of help for us to understand where these new facts coming into action. If you get this working, maybe you can start. Just press here. Okay. Well, this is the history. Well, I deliberately put this slide sideways so I can get some attention. Maybe people can wake up and read the things in sideways. The story here about these two flags represents the newest guidelines. The newest guidelines that's been published. This is, for example, the British published 2015. The previous one was in 2009. And then the Canadian 2014. The previous one was in 2011, I think. But these two major guidelines on thermoprophylaxis in obstetric and gynecology has added two important factors in addition to the usual recommendations for the antepartum and postpartum from the various studies that has been published. And these two are the one we just heard from Dr. Amal, the use of thermoprophylaxis in IVF pregnancies, and I'm talking about the other one, which is the recurrent pregnancy loss. So it seems to be when you review the risk factors, the old list has really expanded to add two more factors, which are the IVF pregnancy and the recurrent pregnancy loss. To include these two in one game of teaching, me as the chairman of the Arab Maternal Fetal Medicine Expert Group, which is across the Arab world from the ocean to the Gulf, have developed a program called WORTH, Women at Risk of Thrombosis. And it has 4 modules, which include both the antepartum postpartum, as well as the IVF and the RPL. We went across the kingdom in 2016. We had actually invaded 8 cities We educated more than 1,000 doctors, and we have actually created a list of educators. And about 18 of them here. Dr. Dr.sheef is one of us. So this is a program that has been developed by this Arab group, and it's really the purpose of just to increase the awareness of doctors among newly addressed topics in this field. The society, which is the Saudi Obegyn Society rule, was mainly to introduce the guidelines in obstetrics and gynecology. And for that purpose, in 2014, a task force was established. I was spearheading it, and about 10 members, you can see them, they're here. And we formulated our Saudi guidelines. We won't really reinvent the wheel. The guidelines, as I mentioned before, and I mentioned somewhere else, it's in British, the American, the Canadian, but we actually tailored it. If you look at the Canadian guidelines, they take about 36 pages, while we did only 6 pages, and in a very informative way. So this is actually under writing now and being published in 2017. Going back to the topic that I'm talking about, which is the recurrent pregnancy loss, again, there is a guidelines for it, all right? But these guidelines published in 2006, so they have no mention about thromboprophylaxis in this guideline. And that's why I don't think this is applicable these days to read a guideline of this caliber. To talk about the subject itself, what is recurrent pregnancy loss? As we all know, we have to have at least 2 pregnancy losses that has been proven by ultrasound as well as histopathology. And even the location has been added now, explained clearly, that if you have an ectopic pregnancy, it still will be considered as a pregnancy loss, all right? Before we used to have to call it just an intrauterine pregnancy loss. This has been introduced by the ISHRI only 2 years ago. So, what kind of losses here we're talking about? Is it something consecutive or non-consecutive? It's an old question. I asked myself this question in 1991, and I had 2 groups, one of them who had consecutive miscarriages, the other group had non-consecutive. And I looked at the outcome after that in their pregnancy. Look at this. I found that the incidence of recurrent of spontaneous abortion after consecutive miscarriages is something like 20%, while if the woman had only non-consecutive miscarriages, it's only 6%, which is within the average or a little bit above the average. So anyway, but there's a big difference between it. It's statistically significant, and that's why when we talk about miscarriages, we have to have recurrent miscarriages. Again, primary or secondary? Well, a woman who has got pregnant, she had a child, and then she had recurrent miscarriages, although maybe consecutive. A woman who did not have any child, from her first pregnancy, she kept losing the pregnancy, and this one is actually what we call the primary. Again, the importance here actually is related to the primary recurrent miscarriages and not the secondary recurrent miscarriages. Next, we can talk about the causes. For example, we have many medical, surgical causes, anatomical causes, genetic, and other different categorization. But the unknown, which is really something very distressing to tell the patient, sorry, I don't know, but it's no harm of doing so. Because we have something like 40 to 60% different figures from the literature that the cause of miscarriage is unknown in these cases. Well, let's talk about maybe some possibilities. Age factor. Age factor can be actually a cause of this recurrent miscarriages. The age is above the age of 40. How did you know about this? When we started doing IVF, when we started to get these oocytes out, we did a little bit of karyotyping on those oocytes, and we found that the incidence of aneuploidy, abnormal karyotypes in the ages above 40, in the 45 and even 49, something ranging between 90 and 100%. So these old oocytes has really abnormal karyotype that may lead to the loss of this one. And then, of course, we have the genetic component. When we talk about the genetic factor itself, is not the maternal or the paternal, it's actually the conceptus itself. So you need to analyze the karyotyping of the conceptus, and this is where the higher incidence of abnormality lies in. Paternal karyotyping has been accused of something like can be a leading cause of this, but it was a very small proportion of less than 1%. The majority, however, lies in some translocations, that is unbalanced translocations in these cases. Now, for that reason, when we start looking at the implantation rate and why we're losing this pregnancy and we're not losing this pregnancy, to confirm this factor in an haploidy fashion, we're doing now what we call the pre-implantation genetic diagnosis. For this, before we put that embryo back again in the uterus, we do our fish analysis, we do our karyotyping, we do our genetic analysis of these chromosomes. And it seems to be that the implantation rate of those embryos who had underwent the PGD analysis is very much higher, which is something like, we're talking about 70 to 80% compared with implantation rate of only 40%. So this difference, because the one we had a PGD, this is a pure group where we have removed the abnormal ones. In this non-PGD cases, which is the control, which include the abnormal karyotypes, and that's why we lose some of them after implantation. Then the anatomical cause of recurrent pregnancy loss, and this is usually diagnosed by hysterosalpingogram or by the MRI. Ultrasound 3D, actually in good hands, becoming the best really tool to diagnose something like this, an intrauterine septum, or maybe didelphus, or bicornuate, unicornuate. But the only anatomical finding in the uterus that is really associated with recurrent pregnancy loss is uterine septum. Anything else is not. So, and the correction of this problem can be done by hysteroscope, which is a very simple day surgery procedure. And look what happened after that. 83% pregnancy rate after this simple procedure. So this is an identifiable cause. The treatment is very trivial, but the result is huge. We can increase the chance to 83% of this lady to have a child by just this correction. This is one anatomical correction for that purpose. Now, endocrine, of course, you have to review the lady's endocrine profile. Thyroid function maybe is one of the things that you need to correct, and that's easily. Now it's the immunological part. This is really what the core of this talk. How the immunological part in recurrent pregnancy loss really lead to that kind of thrombosis, recurrent pregnancy losses. When we talk about immunology, we have two factors you have to identify: the autoimmunity part and the alloimmunization. The autoimmunity, that means something like antibodies in the circulation. I call them the killer antibodies. These are what we know as the antiphospholipid antibodies, which includes the anticardiolipins, lupus anticoagulant, and the beta-2 glycoproteins. However, we have another arm of immunological possibility leading to recurrent pregnancy loss, which is the alloimmunity, which is something like a tissue rejection factor or graft rejection factor that really undergoes some kind of like cytokine interactions and immunological reactions at the level of the placenta, where the placentation actually stops at one stage, not necessarily from the beginning, but at various stages of the pregnancy. And that's why in this alloimmunological reaction, we have a stage of rejection that occurs early, which is pregnancy loss, or maybe sometimes later as a second trimester loss, or even preeclampsia, IUGR, or sometimes even antepartum hemorrhage with abnormal placentation. So these are always like immunological reactions at various degree, at various stages of pregnancy as a result of the alloimmunization rather than the autoimmunization. So this is the stage, and both of them can lead to pregnancy losses. Both of them what we call placental disorders that does not really keep the pregnancy to continue. What about the relation here between these, the current pregnancy losses due to immunological factor and the thrombosis? These are the three statements that at least we can go around it. Well, the many cases of recurrent miscarriages are due to an abnormal or exaggerated hemostasis of responses in the pregnancy. So somehow we know that the pregnancy is hypercoagulable status, but in this case, we may have some additional factors that lead that to thrombosis. And this hypothesis is supported by the data reporting the increased markers of thrombin regeneration among the women who had recurrent pregnancy losses. So there is some kind of interaction with the cascades of thrombosis because of these immunological reactions. An increased prevalence of coagulation defects among women with recurrent pregnancy losses, histological evidence from the placenta itself. I'll come to discuss this in a little while, but here, let's talk about the antiphospholipid syndrome. Well, as I mentioned before, this is the only link of recurrent pregnancy loss and thrombosis. And whenever there is a disease, you have to diagnose it. Now, as far as autoimmune disorders, which is like antiphospholipid syndrome, this is the only acquired thrombophilia, as you all know. And it is occurring in three types, of course, the antibodies, as mentioned before. And it has an incidence of 1 to 5%. However, the incidence of APS is only 0.5%. It occurs in women also who do not have recurrent pregnancy loss. It occurs in men also, but this is the general findings or distribution of the disease. However, only 18% of patients with recurrent pregnancy loss have an APS. So this is where still we have large number proportion of women with recurrent pregnancy loss who we don't know why, as I mentioned before. But only 18% they have that link with the with this APS. So how would you diagnose APS? You need to have two arms, and both of them have to be positive: the clinical and the biochemical. Clinical is your patient's condition. She has to have at least 3 or more consecutive spontaneous abortion less than 10 weeks, or to have 1 or more than 10 weeks, or to have something like a premature delivery related to an IUGR or something like a preeclampsia or abnormal placentation that has been associated with her past history. So this is the clinical assessment. As far as the biochemical or biological criteria, we all know that we need to have one of these three: the anti-cardiolipid antibodies, the lupus anticoagulant, or the beta-glycoprotein being tested, and at least 12 weeks apart, and both occasions has to be positive. After that, you call the patient, she's positive APS. Now, I had a patient coming to me with a period between the two tests, only 10 weeks. I rejected the second test. I told, wait to complete that, because you have to stick to criteria in order to qualify or label your patient as a positive or negative, because the result or the consequences can be really something major. So then what's happening with these APSs? As I said, it's really a disease that occurs at the site of the placentation. Here, the immunological reaction is an antibody reaction. There are many factors that also play, whether it is cytokines, like the TNFs actually, or sometimes the tissue factors, or in addition to annexin, which is another type of antibodies that always it's associated with the microvilli of this placenta. So these villi, sometimes with this interaction, they dissolve. They just undergo what we call apoptosis. Now, the dissolution of these chorionic villi lead to an empty space. It's a hollow because it was lined before these cells, and that's what we call the ghost cells or the ghost villi. And this is what has been reported from many histopathological diagnoses. So this kind of findings is really associated very much with the current pregnancy loss that has a positive APS. In addition, syncytial trophoblast formation. Sometimes the syncytial trophoblast invasion of this, the annular and vessels of the uterine wall lead to expansion or actually even softening of the wall of these vessels, which accommodate the increased flow of these fetuses. If there is lack of these syncytial trophoblast, that will result, there will be narrowing of these circular arterioles, and what will happen, there will be an increased high pressure, and of course, at the end, we'll have a stage of pregnancy where the total loss of blood supply to the fetus or the embryo occur, and the rejection takes place. Now, how these syncytial trophoblast really been affected? This is the secret behind it. The cytotrophoblast, when they are formed and they start to embed itself under the endometrium or the decidua, they need to form what we call the syncytial trophoblast. Syncytial trophoblast is mainly simple cells of cytotrophoblast that glued together by lipids that's called phospholipids. All right, that's what you call the phospholipid molecules. This is the glue. Now, if you have an antibody called anti-phospholipid antibody, then this will take away this glue, and no more syncytial trophoblast will be formed. Syncytial trophoblast, with its, putting it together, is the force that invades into the decidua, that makes the attachment of the embryo into the decidual wall and the uterine wall, which maintain the pregnancy to continue. So this is the actual process that actually will prevent the continuation of pregnancy, and as a result, abortion or miscarriages takes place. From here, we can say that if you have a patient in front of you with recurrent pregnancy loss, and she is positive for antibody, for APS, what do you tell her? You tell her that you have a 3-fold increase incidence of VTE rather than any other pregnant woman. You tell her that she has a 35% risk of early fetal loss. She tells you she has a 17% risk of stillbirth, and also she may have an increased incidence of other complications like preeclampsia, IUGR, and even antepartum hemorrhage or premature labor. Very well, doctor. I understood the situation. What shall I do? This is the answer. You give her the both combination of aspirin and low molecular weight heparin from the time she's diagnosed positive for pregnancy till the end of pregnancy, and for 6 weeks more after the pregnancy. So this is the treatment. This is a treatment because she has a positive APS with recurrent pregnancy losses. We are not going to prevent the pregnancy loss definitely, because we have effectiveness of about 70%. Still, we have 30% of women with these criteria. You give them the aspirin, you give them the low molecular weight heparin, but still they lose the pregnancy. So it's a complicated problem, but at least we have covered 70% of our patients, or the majority of them, with this kind of medication by understanding the problem, and that's why pregnancy went on very well. How these aspirin and heparin works? Well, you can see here that it is really the aspirin works through the reducing the hypercoagulative status and the choriodecidual space. The same thing that we're talking about, the choriodecidual interaction and how the sensitization, the syncytial trophoblast really being formed. So it seems to be that the aspirin as well as the heparin, they work there, whether it is through the immunological, and it has been shown that there is the heparin interact with the tissue factors and stop that immunological interaction to take place, and that's why save those placentas from being rejected. Now, we can talk about other thrombophilia, but I will not go through in depth. The major thing here when we talk about other thrombophilic factors is to recognize that there are some of them major and some of them are low risk. So, antithrombin, as you all know, it's antithrombin itself is actually the natural anticoagulant in the system, and of course the deficiency of that one will lead to thrombosis, and it has actually something like 11 to 40% chance association with pregnancy loss and thrombosis if there is a family history has been recognized in the past history of the patient. Now, we know about protein C and S and the factor V Leiden, and this is the important slide here. It distinguishes between the high risk and the low risk because your prophylactic approach can be different. When we talk about the high risk is the antithrombin deficiency, the homozygotes for factor V Leiden, the homozygotes for the prothrombin gene mutations, and also if we have a double heterozygotes from the other two, which is the C and the S, and of course the heterozygotes PGM or 5 ligand. So if you have a heterozygotes, it's just a low risk. If you have any of those homozygotes, then we have it as a positive, and especially at the thrombin 3. Why we said we distinguish between the two? Because the regimen that we're going to do for prophylaxis is different. If you have, for example, a high risk factor, you need to use what we call in the middle, the intermediate dose, which is a little bit higher, but it's less than the average prophylactic dose, but it is less than the therapeutic dose. And you can see, for example, if you're using enoxaparin, and you give only 40 milligrams for an irregular prophylaxis, if you have a case of high risk thrombophilia, you give her 40 milligrams twice a day, all right? And while of course, the therapeutic range usually you use the formula of 1.5. So just to give you an example here, for example, you have a condition of antithrombin 3 deficiency or APS positive with previous VTE. Your dose has to be here at least using the 50 to 75% of the original dose that she has, or you have to use what we call the intermediate dose in case she has been already on thromboprophylaxis. However, if you have an antithrombin 3 deficiency without the VTE, then all you need to do is just to give her throughout the pregnancy with the regular dose of thromboprophylaxis. And of course, when you talk about high-risk thrombosis, let's come to the conditions when you have a positive antiphospholipid antibodies only. As I said, this is one of the only association of acquired thrombophilia that should be considered. But if it is alone, without previous history of VTE, then you just consider it one of the risk factors. We heard Dr. Abtesam and Dr. Muhammad talking about the risk factors. So these are, in this situation, you consider this is as just one of the risk factors, and then according to the numbers, if you have 3 or 4, then you should be continuing throughout pregnancy. If you have only 1 or 2, maybe you start at 28 weeks, and that's according to the table you have. The reason I put this is about the etiology and the unknown is that just to stress on the factor that you don't need to use heparin empirically for unknown conditions, please, because there is no evidence-based indications or conclusion to support that approach, and there is no harm of saying I don't know. وَمَا أُوتِيتُم مِّنَ الْعِلْمِ إِلَّا قَلِيلًا. Please stick to the evidence-based recommendations. For example, use of aspirin, and I've seen this happen in all clinics of OB/GYN. Doctors, unfortunately, because she had 3 or 4 recurrent pregnancy losses, he wants to increase her chance of having to keep her pregnancy by giving aspirin. Well, we only give aspirin and heparin in cases of positive APS. If she has no APS, no need. And this is the Cochrane say that there is of no benefit. Again, maybe our colleagues, the immunologists, they have different combination of weird stuff like the trophoblast membrane infusion, or take her the husband white cells infiltrated into her bloodstream. All these things has been tried, yes, but you can see there from the p-value and the odd ratio of these results, which was published just about in 2010 in the New England Journal of Medicine, has shown no effect and no benefit. So, cortisone, prednisolone has also been, I mean, to the stage that they reached a stage of almost bleeding in it. But then, of course, the results when it analyzed critically, there were no strong association. Even in the fertility study with the ASRAM recommendations, 2012, they said, well, does not work, does not increase the birth rate. In contrary, it will increase the chance of having hypertension, diabetes, and other complications in that pregnancy whenever cortisone is used. Now, to summarize this and to conclude, I thought I'd use the Canadian guidelines. And I'm putting here in words. You can see the number there, 63. The Canadian guidelines has 67 statements or recommendations. As you can see, it is towards the end because this is a new field that has been discovered. Statement 63 says, universal screening for thrombophilia in women experiencing adverse pregnancy outcomes, severe preeclampsia, intrauterine growth retardation, or stillbirth is not indicated 2C or 2D. The woman with recurrent miscarriage or late pregnancy loss should be screened for antiphospholipid syndrome only. So you do that, and because of these recurrent miscarriages and IV. It's a stage evidence 1B. Low dose acetylsalicylic acid, the aspirin, and the molecular weight heparin is the recommended in pregnancy in women with confirmed APS 1C. So it's recommended in cases of recurrent pregnancy loss with APS. And low dose, again, they stated, look at this. They said again, the aspirin and the heparin, all right, for women with a history of recurrent miscarriage in the absence of confirmed APS syndrome actually is not indicated. So it's not just they send the statement, they said the opposite of that in clearly to tell you all those people who are playing with heparin and giving patients with recurrent pregnancy loss, oh, this will keep your pregnancy, is of no use and is not supported by evidence. Low-dose molecular weight heparin should not be used routinely to reduce the risk of recurrent placental-mediated complication in women with or without thrombophilia, excluding antiphospholipid syndrome. So even thrombophilia is not just hearing the cause, it's not really the cause and give you the chance or the reason to start on it. So it's clear they have actually used what we call the contrary and the absolutely statements for this part to be clear about the situation and not to get mixed up. Here we have a condition that has been studied where the molecular at the molecular level where we found the relationship exists whenever there is antiphospholipid syndrome. And thank you very much.
السلام عليكم. أنا Hisham Arab, adult hematologist from King Faisal Specialist Hospital. If you could start questions. I'll ask a question because I am older than Hisham. And he mentioned that 40% you don't know what is the cause of these miscarriages. And this is a provocative question. And people, they don't have the sophisticated labs to do antiphospholipids or thrombophilia. I would think, I mean, why don't they start on aspirin and heparin without confirming these diagnoses?
Very provocative. Thank you very much for that. Well, when I say 40% they don't have a cause, that means we went through not really the thrombophilia screening and the big thing, big shots. Here we talk about the routine gynecological investigations. Like any woman, patient walk to you and you have a history here or a story about recurrent pregnancy loss, of course, you do the ultrasound, you do the hormones, you do the history and physical, and the only test that you need to do is the APS, the antiphospholipid and the anticardiolipid antibodies, and lupus anticoagulant. You don't need to do the thrombophilia screen at all. So, but I think this is also available in all labs, whether private or hospital. And after doing this, we have still a high proportion, 40, and some people say 60%. We don't know the reason. So it's not really a big deal.
Yeah, because we see patients from north and south, and they don't have these investigations. And we see pregnant women with loss, and they're still on aspirin and heparin.
Yeah, but the thing is, putting them on aspirin or heparin without doing that testing, the APS testing, and even if it was negative, it was negative, putting them on in these medications is, I think, more hazardous on the patient, and I think you are really abusing the drug in itself.
Assalamu alaikum. I'm Dr. Wissam, Assistant Consultant OB-GYN KFMC. Now my question is, because I just came late, thrombophilia screening is not indicated to be done for recurrent pregnancy loss, isn't it?
Yes.
So the studies confirm that congenital thrombophilia won't make the patient to have recurrent pregnancy loss?
That's right.
And all the other complications like IUGR, intrafetal death, preeclampsia, no more? It's only the APS which causes all these complications.
Exactly. The only test you do from thrombophilia screening which is the APS, the anticardial antibodies. But the rest of the thrombophilia screen is not indicated if a patient had previous IUGR, previous preeclampsia, previous recurrent pregnancy loss. All these adverse pregnancy outcomes are not an indication to proceed for a thrombophilia screen.
And these tests, the APS, we should do it before pregnancy. We didn't do it through pregnancy, isn't it? Because the levels are changes in pregnancy.
Absolutely. I always tell them, you see, when you have a patient aborting her third time, and you don't have on your records whether she had an APS or not, it's not your fault. It's the fault of the previous doctor who saw her at the second miscarriage. Whenever you see a patient aborting her second miscarriage, before she leaves the hospital or your clinic, send her for APS.
Yes.
And do your APS assessment. So, well, if you saw her the third time, nothing been done, okay, you have to proceed, but it should have been done in order to have an open in your hand. So you can, whenever she got pregnant next time, she should be on or not according to the results.
So after 2 miscarriages, I can go for these tests. I don't want to wait till the 3rd miscarriage happens, then I do it. Because patients cannot wait. All the time they complain, why you want me to lose my 3rd baby, then you start investigating me.
Exactly. You just, if first time, you don't do anything. But second time pregnancy, I'm not waiting for the post-abortion visits or 1 month later visit. No, immediately you send her for first testing. 3 months later, you send her for the second testing. And that's why you have identified her whether she is a case for...
So if she aborted and then immediately I collected the blood, still it is available and it will be a correct results?
Absolutely.
In spite that the hormones of the pregnancy, still the effect is there? Because we usually do it 6 weeks post any abortion or preterm delivery or whatsoever.
The value, the result of these investigations after abortion, not talking during pregnancy.
Yes.
Usually the level of beta-CG and the hormonal milieu is very limited, so it will not affect it at all.
So, thank you a lot.
If with patient with antiphospholipid antibody, when do you start with miscarriages? When do you start prophylaxis?
Immediately with her next pregnancy, from the day she has a positive pregnancy test. And you tell her that if you diagnose her and you thought, okay, we're going to get pregnant. But at the same time, you tell her, okay, the minute you have a pregnancy test positive, you come to me, I'll give you the heparin and aspirin. And you continue throughout pregnancy and 6 weeks postpartum.
Because you mentioned most of ABS patient, most patients with obstetric ABS, they do very well with prophylactic dose of low-molecular heparin and aspirin. But subset of patients, luckily minority, they have recurrent pregnancy loss in spite on prophylactic. And we have some cases in spite on full dose anticoagulation, still they have miscarriage, mainly intrauterine fetal death. We have about 4 patients still following in our clinic. We put them on IVIG in addition to full dose anticoagulation. Luckily, all of them, they are doing fine. I know this is the last resort. We are not, advocating to do it for all patients. Patients who are resistant, refractory for all other measures, as the last resort, IVIG, and it is effective. But it is, imagine that a patient will come every 2 weeks for daycare to receive IVIG. I know this is hectic, cumbersome, but it's life-saving and expensive, but life-saving. Imagine that this is a precious, pregnancy. 5, we have patients 7 or 5, 1, 5, 1, 6, 1, 7, recurrent pregnancy loss. So we use it, and still, hopefully, that will end up with a successful result. When you started? We started immediately, and every 2 weeks. It depends. There is a protocol if the patient having early pregnancy loss or if the patient having late pregnancy loss after 20 weeks, like intrauterine fetal death. So we have a protocol initiation and the frequency. But this is all done in consultation with Dr. Hazza Zaharan, because he have started this earlier and he has 10 cases. He tried IVIG. So we are just sharing our experience with King Faisal Specialist Hospital.
Yeah, it's nice to hear this, but still, it's not the current recommendation. It's a trial you are doing, which is really, a good thing maybe to cover the 30% who actually fail despite being on aspirin as well as heparin.
Maybe I missed this one. If you have this for a chief or another, if you have a patient with antiphospholipid antibody documented, I don't know how documented, but there are no thrombosis and no pregnancy loss, what to do during the pregnancy?
Why was checked? Why was checked if the patient have no obstetric? Yes, if the patient indication to screen for antiphospholipid syndrome, but if the patient having positive, because it depends the answer, because antiphospholipid antibodies are heterogeneous groups. If it is lupus anticoagulant, strongly associated with recurrent pregnancy loss. If it is anticardiolipin, for example, is less. Beta-2-glycoprotein, is it dual positive? Is it triple positive? If the patient having successful pregnancy without anything, I will not give him anything. I don't know what else.
No, this is exactly what I was saying, Fahad. The positive APS alone, without previous recurrent pregnancy loss, just positive APS, it goes as a factor, as one of the risk factors in the list. So it's counted as one, and then look at other factor, age, parity, whatever, and add it on to make your score for the recommendation to use or not use heparin. Yeah.
Yeah. Here is coming risk assessment antenatally. We should do risk assessment, look for other risk factors. ABS, no previous pregnancy complications, no other concomitant risk factors for VTE, so no need to start. It's no indication.
Can I just mention, Dr. Amal, you did very well with your presentation. Thank you very much. I just want, very well with your presentation. Thank you very much. It's just one thing regarding the OHSS-related thrombosis. Usually it's not in the lower limb, remember this, okay? It's in the upper limbs, the cervical, subclavian veins, whatever, or even intracranial ganglion. So I've seen reports came, they did the Doppler on the lower limbs, and it's negative. So I said, this in OHSS, don't do lower limb Doppler, you do upper limb and as well as subclavian Doppler or even intracranial, looking for a thrombus if you're looking for something. Thank you.
Thank you. Dr. Hisham, sorry, I have one question. Just, I'm doing a high-risk pregnancy, and I receive cases already started on heparin empirically and aspirin from outside. And the patient believe on that because she lost 2 pregnancies, and this is the 3rd pregnancy. It's not diagnosed in the polyclinic or any centers for thrombophilia or antiphospholipid, and she's on aspirin and Clexane. At that stage, shall I stop her aspirin and Clexane or let her to continue? And what's your opinion in this cases? It's very difficult, but it's a hazard treatment, and there is no justification when you start that treatment because again, it's induced osteoporosis, and it's not an easy drug to be used for 40 weeks or 38 weeks from her pregnancies.
Well, it's not an unusual circumstances these days.
This is usual, Doctor, because we tertiary care and we receive patient after 24 weeks, and based on somebody recommend for her, it's not diagnosed at all. Sometimes she came in her 5th pregnancy just based on her previous 2 history of miscarriage, and she started aspirin by herself and Clexane by her physician at that time or obstetrician at that time.
I'll tell you what I do.
What you
Of course, the patient comes with this bag of all these Clexane and other things inside it, all right? I take the bag from her and I put it in the trash pan. I deliberately in front of her, doing this, I tell her, you don't need this. You have to be convincing. You have to be brave. And then you take the phone call, the phone number of her doctor, and tell them what is the right thing to do. Because, and especially if you start to, this is between you and the doctor, to talk about these dangers and the risk and the patient, and you will not support him or her in court if something happened to this patient. The doctor immediately will listen to you and will give up and tell him your patient is coming back to you, and she'll have another word from you to say, no need is enough, and that's it. So I won't let her continue.
Thank you.
I think, but you have to have a trash can in your clinic.